This video is produced by the UCLA School of Dentistry and is intended to give an overview on protective stabilization. Protective stabilization is the restriction of patients' freedom of movement with or without the patient's permission to decrease the risk of injury while allowing safe completion of treatment. Protective stabilization is used to protect the patient, staff, dentist, or parent from injury and to facilitate the delivery of quality dental treatment. The restriction may involve another human, a patient stabilization device, or a combination thereof. It is used in the treatment of infants, children, adolescents, or a patient with special healthcare needs. Examples of protective stabilization devices can include the papoose board, pedi wrap, or in the instance of human stabilization, knee-to-knee stabilization.
There are two types of protective stabilization. One is active immobilization, which includes another human, such as dentist, assistant, or parent. It includes head and hand holding and restraint of the lower extremities. The other is passive immobilization, which uses a restrictive device such as PD wrap or a papoose board.
Prior to dental treatment, dentists must first give a thorough explanation and obtain informed consent for stabilization from the parents. The documentation must record and include the following: indication for stabilization, type of stabilization, the duration of application of stabilization, and the behavior evaluation during stabilization.
Protective stabilization is indicated for patients who require immediate treatment and cannot cooperate due to lack of maturity or have mental or physical disability. The safety of the patient, staff, dentist, or parent who would be at risk without the use of protective stabilization. And limited stabilization for sedated patients to help reduce untoward movements. Contraindications for protective stabilization include cooperative non-sedated patients, patients who cannot be immobilized safely due to associated medical or physical conditions, patients who have experienced previous physical or psychological trauma from protective stabilization, and patients who require lengthy appointments.
After you have reviewed child's medical history and generate a treatment plan based on child's dental needs, you must assess if the child is indicated for protective stabilization, which we have discussed earlier. Dentists must consider child's oral health needs, emotional and cognitive development level, medical and physical conditions, and parental preference.
Protective stabilization can only be used if less restrictive intervention, such as communicative guidance behavior, is not effective. It should not be used as a means of discipline or convenience. It should certainly not hurt the patient. If a stabilization device is used, tightness of the strap must be monitored and reassessed at regular intervals to make sure that respiration and blood flow are not compromised.